Ladies and gentlemen, thank you for joining MPRO's webinar on colorectal cancer screenings, evidence-based recommendations for best practices. Your host for today, Julie Campbell, will begin.
Good afternoon and welcome to today's webinar presented by MPRO. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you'd like to learn more, please visit cancercontrol.mpro.org. If you'd like to download a copy of today's slides, they'll be uploaded to our website. And again, that's cancercontrol.mpro.org under the colorectal cancer section. Today's speaker is Debbie Webster, Cancer Patient Navigation Consultant with the Michigan Department of Health and Human Services. Debbie is going to be talking with us today about patient navigation and how these services can support screening for colorectal cancer. Participants can feel free to submit questions via the chat box, and we'll also open the phone queue for questions at the end of the presentation. At this time, I would like to turn it over to Debbie.
Thank you. I am pleased to be speaking with you all today. I always start talks about navigation talking a little bit about cancer screening disparities. So you see on the slide before you that in 2012, the Centers for Disease Control produced a report that detailed screening rates for different populations of people. This report looks at national data and can help us understand where our focused efforts might need to be placed when we look at increasing colorectal cancer screening. You can see that the lowest screening rates are in those people without a regular care provider. This is logical, as research has shown that provider recommendation is the #1 reason people state they have completed their colorectal cancer screening. The lack of insurance is also very logical, as many providers rely on colonoscopies for their colorectal cancer screening method, and colonoscopies can be very expensive without the help of insurance. I'm going to talk a little bit more about this later, but this is one of the reasons that the Michigan Department of Health and Human Services recommends that patients be given the choice for their colorectal cancer screening. You're also going to note that both Hispanic and American Indians are two population groups that have lower cancer screening rates. Other population groups like Arab Americans were not individually collected in this testing format. However, Michigan has done some surveillance testing with African Americans and found that colorectal cancer screening rates are low within that population as well. There's also slightly lower rates in men in rural populations. All right, moving on. Now I'm switching to state of Michigan data. And I'm moving forward a few years, so don't compare those cancer screening rates at all. So this is Michigan data looking at 2015, what we were talking about before was 2012 data and national. So that you can see here that Michigan's current overall cancer screening rate is estimated to be about 71.6%. However, I have pulled out a couple of other areas of disparities to look at here. While college graduates are much more likely to be screened, with 77% being reporting they have had their cancer screening, those people who did not complete high school, their screening rates are very much lower at 60.2%. And the Michigan Behavioral Risk Factor Survey, which is where I got this data from, doesn't go to the county level. So then I turn to U.S. Census data to kind of say, how does this differ in different counties? And I'm not sure where you all are from, but what I was able to find was that there are huge differences in educational attainment depending on what county you're in. If you look at like Wayne County, which is where Detroit is, and Lake County, which is in the northern part of the lower peninsula, you know, Wayne and Lake have very low education attainment levels. And so we can, you know, deduce that it's probable that in those counties some of our cancer screening rates would be lower. The other thing that I think is interesting to note is, even in an area like Washtenaw County, where we have a very high educational attainment, there still are, really, when you think about 5.5% of the population in Washtenaw County did not graduate from high school. If you think about all of the people in Washtenaw County, that still is an awful lot of people. And moving on, I also did the same thing with income level. If you make less than $10,000 a year, your screening rate is 57%. If you make $50,000 or more, it's 76.7%. So again, when you look at your patient population, you can start, looking and seeing that at some level there are people who just are less likely to be screened. And again, I'll pull you to the county level data and the fact that there's just huge ranges in income attainment across all of our counties, with, again, Washtenaw County being our most affluent county and Lake County being our least affluent county. But in both of those counties, there are still going to be, hundreds, probably thousands of people who make less than $10,000 a year. And especially when we're talking about colorectal cancer screening, this is huge. This is important. A colonoscopy can cost, upwards of $2,000, $3,000, or even $4,000, depending on how it's done and what other tests are involved. And if I made less than $10,000 a year, I certainly couldn't put, a third of my income into one medical test. I wouldn't do it. And so I think it's something for us to really kind of take in consideration when we talk about colorectal cancer screening. Okay, so now I want to transition my talk to really talk about what is patient navigation. So patient navigation can be a lot of different things, but at its core there are two key issues. One is individual barriers, looking at the patient in front of you and saying, what is it that's preventing him or her from completing the screening test or the diagnostic test or getting into treatment? What is it about Joe or Jose or whoever your patient is, what's standing in his or her way with getting this done, and then working to address that. And we'll talk a little bit about what some of those barriers can be, but that's kind of the key point of navigation, is those individual barriers. Timeliness of care is the other really core piece. Before navigation was instituted, there were people who were much slower and much less likely to get the screening, diagnostics, kind of intro to treatment done in a timely fashion. And navigation truly has been able to address that. The last thing that I kind of put on this slide, because I wanted to say it up front, is that patient navigation is a system and it's not a person. I think a lot of times when we talk about patient navigation, people think about patient navigators. And I certainly heard from providers' offices, well, we can't afford to hire a patient navigator. And I think that makes a lot of sense. Money in provider offices are very, very tight. So we're not necessarily advocating the hiring of another person, but looking at what can be done within the structure of your office already and making some changes to kind of address pieces and parts of what might be those barriers and how to fix them for your patient. Okay, so what can patient navigation do in colorectal cancer screening? I'll get into the evidence here in a few minutes, but navigation can reduce health disparities by eliminating barriers to care. It can improve colorectal cancer screening rates. It can improve the completion of FOBT or FIT, getting those back into the offices. It can improve the completion of colonoscopy preps, and that sentence is worded a little wonky, so I apologize. And it can reduce colonoscopy no-show rates. All right, so The very first navigation study was done by a man named Dr. Harold Freeman, who is a breast cancer surgeon in Harlem, New York. And what Dr. Freeman was noticing is that the women that were coming to him were coming in and seeking help when they were at a very advanced form of breast cancer. And because of that, the 5-year survival rates of those cancers was really low, 39%. And for the same time period, the survival rate for white women was about 60%, 5-year survival rate. So he asked himself, why are these women coming in so late? Why are we getting all of these stage 3 and 4 cancers? And he started looking at what the barriers were for these women getting in and getting their services. And once he identified what those were, he put together the first navigation program. And he started looking at and getting, people out in the communities, working with the women and doing this navigation, identifying the barriers, fixing the barriers, and moving on. And what he was able to show was that navigation worked. And you can see here in the data, the stage 0 to 1 diagnostics went from 6% before he instituted navigation to 41%. So the women were just getting identified earlier. We were catching the cancers earlier. Similarly, the stage 3 and 4 rates went down dramatically. And not surprisingly, the 5-year survival rates went up from the 39% that he'd observed early on to 70%. So once he published the study, there was a lot of interest and attention in navigation. And there has been, since I haven't counted them, hundreds, I can easily say hundreds of studies that have worked to look at navigation and does it work, and, kind of proving Dr. Freeman's results. And so I listed for you 4 studies, kind of arranging in different things, but if you're interested in more, as I said, there's hundreds of studies. All you have to do is Google. But NASH in 2006 was able to show that colonoscopy no-shows were reduced with the institution of navigation from 67% to 5%. That's pretty significant results. Chen also did some work on this. He looked at the question of what does navigation do to poor bowel prep, and showed that the bowel prep, the poor bowel prep rate decreased with the institution of navigation. Breast and cervical one is the one I have here, and this one was showing that women were more likely to have that timely follow-up and diagnostic evaluations, which I told you is kind of one of the key frames of navigation. And then this last study I put in because I found it very interesting, and there's lots of research that's been done around that. Because Dietrich was asking the question, well, certainly if I've got somebody doing a whole big intervention and lots of things, and we're putting tons of time into this, certainly navigation can make a difference. But what Dietrich did in his study was really look at, what if I just do one piece? What if I just institute some telephone follow-up and look at, what happens there. And he found, he was looking at mammography, PAPs, and colorectal cancer screening, found that just that simple telephone follow-up work increased cancer screening rates. And so, there is a lot of evidence behind navigation at this point. So I want you to pause a moment and just look at these 2 pictures. What are the differences between the 2 pictures? Answer that question for yourself. And then ask yourself, which ladder would you rather climb? Now, if we were in person, I'd solicit answers from you, but I can tell you I've done this training lots and lots of times, and I've never had anybody tell me they wanted to climb the ladder on the right. Pretty much everybody likes the ladder on the left, and if I ask them why, they tell me that the ladder on the left has all of its rungs, and of course it's easier to climb a ladder with all of its rungs. And the reason I use this when I talk about navigation is I think it really describes what navigation is here to do. And it's why I talk about disparities before I ever talk about navigation. I think what we're seeing here is kind of the journey to cancer screening. I would much rather, if I'm trying to get my colorectal cancer screening, have this to be a simple and easy journey up the ladder. But for a lot of our patients, it really looks like what's happening on the right. Their employer doesn't support time off of work or doesn't pay time off of work. They don't have somebody that can take them to the doctor's office when they're having a scope. They may not have insurance. They may not have family support. There could be lots of different things. And ultimately, what happens is that we don't necessarily pay attention to or think about the things that are standing in their way to getting successfully to that cancer screening completion. And because of that, we miss opportunities to help them have that smooth and seamless journey, through the cancer screening process. Oh, okay. So the next thing I always want to address when I'm talking about navigation is no-shows. Now, I'm a nurse. I've had the thought. Life would be simpler if people just listen to what we in the medical field say and just just get it done. And but I can tell you, since I started looking at patient navigation, non-compliance is not in my language anymore. Because the bottom line is I think I, as a nurse, and I think we as medical professionals, too often expect our patients to follow through on what we ask them to do without us spending enough time looking at what might be standing in their way. And that I am much more increasingly doing, that old proverb of walk a mile in my shoes than I used to in the past, because there are so many different things that stand in the way of our patients completing what we ask them to do, and too often we don't look at what those are. If your provider is a provider that, recommends colonoscopies only and doesn't consider a fit option, does that provider know whether or not the patient has insurance, or if they have insurance, is that scope covered by their insurance, and those types of things. It's not fun to receive a $4,000 bill surprise, and that happens to some of our people. And I think we need to, do a better look at, what might be standing in the way. Okay, so what are some of the barriers to colorectal cancer screening? Well, cancer screening in general, actually, for most of these. So there's the ones that it's easy to focus on, the financial aspect. Obviously, lack of insurance is huge. It's a huge barrier, especially in colorectal cancer screening, because it can be so expensive. Transportation to the facility. Do I have somebody that can be there and bring me home? Most GI practices require somebody that sits there for the entire time that the test is being done, and that requires a whole other person to be out of work in order to sit there for the colonoscopy. Competing health, family, and work responsibilities. Do they have child care issues? Do they have sick time or lack sick time? Are they afraid they're going to lose their job if they take time off to do the prep and then to do the colonoscopy? Those are real issues, and I think we need to take those in consideration when we're looking at, recommending this test for our people. Cultural or language issues, certainly can be in the way. For some cultures, a colonoscopy and, just the whole anal penetration and all of those things create more problems than for other cultures. And so that's something that you kind of need to be aware of and think about. There are prohibitions about, women in some cultures, and women being, in an undressed state and with none present. And, those are all things that you need to be thinking about when we're walking through some of these tests. The healthcare system, we are a barrier. We certainly, I think we know that about ourselves. Our care is fragmented. Sometimes the left hand doesn't know what the right hand is doing. We don't necessarily always communicate well between primary care offices and specialist offices. So I think all of those things can get in the way and cause frustration for our patients. Biases based on race and culture. This is kind of pointing out that some patients don't really trust us all that well, and I think that's just something, we need to keep in mind if we're working with, people, that represent different races and cultures from us. There have been instances where we haven't necessarily always been trustworthy, and I think we have to accept that and keep that in as a factor of working with our patients. Fear is another barrier. These tasks themselves can be something that produces fear. I don't know what's going to happen when I'm, asleep. What are you going to do with me? Can I trust you to interact with me while I'm asleep? Fear can also be fear of cancer. Certainly we've run into instances where people, have a fatalistic view of cancer. If I think I'm going to die, if I get cancer, then why the heck do I want to get the test and find that out early? I'm going to die anyway. Now, certainly we know that's not true in colorectal cancer, and we actually can prevent colorectal cancer, through cancer screening. But, people don't necessarily know that, and they need the education in order to combat some of that fear. Colorectal cancer screening it has an ick factor to it that's a little bit different than like breast cancer screening. One of my colleagues always says it's not pink and it's not pretty. We're dealing with poop. We're dealing with, colonoscopies. We're dealing with PrEP. We're dealing with these types of things. There's nothing real pretty about this, but it's real important. And so I think, talking to the patients and helping them understand we get it. It's not real pretty. On the other hand, it's important. It is something that, is important to do. And then I already kind of touched on it. Lack of knowledge. We can't assume that our patients really understand what cancer screening does and how that impacts cancer. So why is navigation important in colorectal cancer screening? Well, I kind of referred to it already. The best time to be tested is when you have no symptoms. We actually can prevent colorectal cancer by removing polyps before they become cancerous. And we certainly can move into early treatment if we do that. By the time somebody has symptoms, we're usually dealing with a pretty advanced cancer, so we want to get these early. The FOBT FIT process requires patients to collect fecal samples at home. Do they know how to do that? Do they understand why they need to do it and what, your particular test? What are the pieces that go with that? For some people, there are multiple steps. They do a FIT, and then they have a positive, and then they need a doctor appointment because now they've got to get a colonoscopy, and they need to understand the PrEP and all of the pieces and parts. And so, moving people through all of those steps is something that colorectal cancer navigation can do. Colonoscopy itself presents barriers. The test is daunting. We've talked about that. It has a complicated PrEP. It requires somebody to be with you at the GI site. All of those things are barriers that at some level are a little bit different than some of our other cancer screenings. And there's a high no-show rate for the procedure, which wastes, medical resources. So those are why we advocate navigation. So one of the things I wanted to point out is this was a study that was done by one of the health systems here in the state, and they asked themselves, we've got this really high no-show rate, cancellation rate for these scopes, and they happen at such a point where we can't necessarily get somebody else in to take the place. And so we've got all the staff and all the resources and everything sitting here, so we now have a loss. So they asked themselves the question, I wonder what would happen if we came up with an alternative to transportation. So they instituted and contracted with Life EMS, which is a mobility transportation unit. These people are medically trained, and what they do is they are the staff person that accompanies the patient. So the GI office can release the patient, and the patient doesn't have to have their own second person. They also institute gas cards, so they did kind of a combination of different things. And what ended up happening is their cancellation rate decreased by 54%, and which saved them thousands of dollars. They continue this to this day because what they're getting is far greater than what they're losing by paying out of their pockets for these patients' transportations, because the patients are completing their scopes. All right. So how do you develop a navigation program? And if you're in a doctor's office and you're saying, okay, sounds great, but how do we do this? I think, you need to look at one of the things. I was telling you about Dietrich and how Dietrich says, any intervention is helpful. And so what I want you to, think about is what is it that's possible in your office. You want to clearly define your responsibilities. Figure out who in your office might be able to fill some of these Navigator roles. It doesn't have to be the physician. It doesn't have to be the MA or the nurse. The office front desk staff can help in some of these things. They can start the process. They can do some follow-up calls, looking at those different types of things. Develop some office policies and procedures. Figure out if you're working with, the front desk staff, what training might they need in order to be able to help. And, is there any written educational materials you have that might be able to support some of these things? It always works best if you find a champion, somebody who's going to see this process through. A couple of things that are very, very easy to do is to schedule appointments, colonoscopy appointments before patients ever walk out the door. Not expect them to make the phone call and set it up. Some will, some won't. Passing out FOBT or fit kits before they ever leave your office is another way to do that. Developing a step-by-step tracking system is another relatively simple intervention. If the doctor recommended that they have colorectal cancer screening, what tests are they getting and did they complete it? Following up with the people who didn't necessarily follow through as the doctor requested. And then, contacting the patient, making sure everything's complete, the results, they know when they need to be rescreened and so on. So as I said, patient navigation isn't a person. It can be a person, but it can be a team. So ask yourself who in your office might be able to do some of these things. Who can ask questions about transportation, who can, provide education about the different choices for colorectal cancer screening, all of those different types of things. So looking at that, I think, is a great way to kind of address how to build navigation into your team. So navigation starts with education. Patients aren't going to complete the screening if they don't know that it's important. Explain the process to them so they're not afraid. They're more likely to follow through if they get why they're doing it and what this testing will entail. And I have here used plain language, and that is super duper important because I think sometimes we tend to talk about things much more in medical language. And, remember, every area has a level of relatively uneducated people. You may have people in your practice who can't even read. You give them a brochure, they'll never read it because they can't. And they may not be likely to tell you. So use pictures, diagrams, in simple language when you're doing some of the education about this. Discussing screening choices is also very important. We talked about this. If I have a low income and and it's going to take a huge chunk of my resources in order to complete a colonoscopy, I may be less likely to do it, or maybe my employer isn't very flexible in being able to do take time off of work for the prep and the completion of the colonoscopy is going to be a problem. Really looking at some of those things. The test, the most important test is the test that the patient will complete. So adding an element of discussing screening choices to your work with your patients is probably one of the best interventions that you can do. Okay, FOBT FIT screening. We advocate that you actually open up a sample kit, show them what the kit is about, how you might select the samples. Any of those, most of those tests have, very complicated, very word-dense, instruction manuals, and you've got people sitting at home on the toilet trying to figure out what needs to be done. We had a navigator that actually followed the instructions to a T, and ended up, she had a nice piece of saran wrap laying over her toilet to collect the sample. She happened to urinate while she was doing it and had urine all over the floor. I think, really looking through and doing some of that education is a great way to get some of those FOBTs or FITs back in the office. Self-addressed stamped envelopes are another piece. If it makes it easy to get it back in the office, you're more likely to get it. Following up with clients and making sure that they complete the tests, or if there's barriers or if they've got questions, all of those things will increase your FOBT completion rate. Informing positive results for FIT by phone and discussing the need for diagnostic colonoscopy is another important intervention. And informing of them with negative results by letter, but if you're doing an FOBT, making sure they understand they have to redo this in a year. FOBTs are only a reliable test if they're completed annually. All right. So, following up with them if the tests don't come back, that is what this example is about. Oh, and placing the client name on the FOBT kit. My doctor has told me this one, that, if the patient completes the test, doesn't write their name on it, and the test comes back in the mail, there's typically more than one FOBT kit or FIT kit that has been given out by the office. And so one of the things you can do to, prevent getting back this, kit with no name on it is just to put the name on it before they ever leave. All right, in colorectal, in colonoscopy navigation, certainly we need to do the education on the tests and the prep, assist with scheduling as is needed, looking at what are the barriers. Why wouldn't they complete this, and what can you do about that so we can get those no-show rates down? If transportation is an issue, it's an issue, and we need to address that, or they are likely to no-show. If they don't know how to do the prep, all of a sudden at the last minute they're going to be panicking, or they're going to do it incorrectly, and then we're in there and we have an inadequate prep and we can't complete the screening. Patient reminders are great, and the beautiful thing about patient reminders in colonoscopy is that you can address the prep questions. So do you have all of the things you need for the prep? Do you have the fluids? It's really, really important that you get your fluids when you're doing your prep. If you don't have adequate fluids, you probably won't clean out all of the stool, and then your test won't be complete. And this is one that I think we tend to de-emphasize. We've run into physicians who just said, I'll just go NPO, I'm just not going to eat or drink anything, and I'll take your prep meds and everything, and it's like, whoa, stop. And these are physicians. If you have no fluid coming in, you're not going to get the stool out. We need everything nice and moist in order to move that stool along. Help address any fears that they have, and looking at cultural barriers. So education on prep, I talked about that a little bit. Advocating for low cost of purchasing colonoscopy prep supplies for patients, I think, can be very helpful. Again, I don't know how often your physicians take a look at, what are the costs of the prep that they're recommending and whether the patients can afford that. But all of that can be important. Translation services can certainly help with those people who have language barriers. One of the things that we've come across lately is an understanding that our homeless patients need special navigation assistance because those of us who have homes, when we do our prep at home, and we have easy access to a restroom. Our homeless people do not. So if you serve a homeless population, you're going to need to make special arrangements for where they can go in order to have access to a restroom. And we've had, several offices that have had a lot of success in finding locations for patients to do that. And availability of a driver is another thing to kind of take a look at. Okay. So roles of the CRC Navigator in cancer. So if there's a cancer diagnosis, we need to make sure they're connected with the treatment providers and assessment and intervention for barriers that might interfere with treatment. Hopefully there'll be a navigator on the other side, but just making sure your patients are connected and going smoothly into the treatment area is part of what we recommend. So what are the navigator tools? Face-to-face meetings, educational materials, phone calls, postcards, letters, all of those things can be helpful. But, probably one of the most important things is that network of referral services. So our people that work with, the homeless population, they now have a network of referral services for people who are homeless. So what are the referral services that your patients might need as you start down this journey? So addressing barriers. So the bottom line is in navigation, we need to know what is going to prevent our patients from following through with cancer screening, what can we do to address those barriers, and then the third element is if we see common barriers, for a larger group of people working on fixing that, so can we get appointments available after hours? Can we, get the doctor to choose a different colonoscopy prep solution that's maybe a little cheaper, doing those types of things. So we can do it at that individual level, but I think it's also important to, look at if we're seeing common themes, what can we do to address that for all? All right, just a couple more slides. One of the things that Michigan has, we're one of 6 states that has a low-income screening program. It's called the Michigan CRC Early Detection Program. It provides it provides cancer screening, colorectal cancer screening for low-income men and women who are less than 250% of the federal poverty level. And you can look those up online, or certainly, we can get you information about that. They have to be between the ages of 50 and 64. They cannot have any symptoms or be high risk for colorectal cancer, i.e. have Crohn's disease, and they have to be uninsured or underinsured. So what does this program provide? It provides a colonoscopy for all eligible clients. We pay for the colonoscopy. If a patients are more comfortable doing a FIT, we have FITs that are available if they're at average risk. So our program will serve average risk, increased risk people. If they're average risk, they have the choice to do a FIT test. If they're increased risk, they'll have to do the colonoscopy, but we've integrated that choice component into our program. And what does it cover? It covers FIT or colonoscopy services. If it's positive, as I said, it covers the diagnostic colonoscopy. We pay for basic lab work, the EKG, office visit, if any of those are needed. Navigation to reduce the barriers to screening. There should be no out-of-pocket expenses. We pay for the prep. We pay for all of that. Treatment for cancer is not covered but our coordinators really work hard to get anybody diagnosed with cancer connected to treatment in the community. This program is not available statewide, so I did put in kind of an image of where it is available, and so you can see if it's in your area. We'd be happy to take referrals of your patients into the program. And I did not give you any way to contact those people. That was something I was supposed to add and did not. So if you're running into patients that need this type of service, it's okay to contact us here at the state, and we can connect you to the appropriate program. And I did include on the resources part of this a link to the program, and that would have our phone numbers and the phone numbers of the different counties that provide this. Now, if you do have patients that are not in those highlighted counties but are nearby or at a long distance but willing to travel, we would provide service to anyone who lives in the state. They don't have to live in those counties, but they would probably have to be willing to travel because we don't have contracts. And we could do the fit by mail, so that is always an option. Okay, so the bottom line is you can make a difference in colorectal cancer screening. You can make big changes, you can make small changes. Basically, what you need to do is just use something. Conversation with the provider is the single most important factor with screening completion. You know, promote risk-appropriate screening options, those choices. Develop systems to track and explore ways to increase your colorectal cancer screening and tracking. That's a relatively simple way to do that. And following up to ensure that tests are completed. You know, none of those really are real-time consuming, and all can be done. All right, so here's my resources slide, and I am back.
All right, great. Thank you so much, Debbie. At this time, we would like to make the evaluation questions available to all attendees. Please take a moment to let us know your thoughts on today's session. We do use participant feedback from these evaluations when we're planning our future learning sessions. And also at this time, we'd like to open the line for any questions that participants might have for Debbie. And I'm not sure if any might have come in through the chat box during the session.
Well, ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And Julie, I'm waiting for callers to join the queue at this present time.
Okay, thank you. While we're waiting to see if anyone has any other questions, Debbie, I did have a question kind of about the transportation piece of this. So are there resources that primary care providers can be accessing to kind of start coordinating transportation for patients to get to colonoscopies or other services like that?
I think, you know, probably the best resource in general would be to go to 211. And that is one of the resources that we have on the reference page, the resource page. It's that first resource there. So, you know, look at that. But calling 211 usually is your best idea of what resources might be available in your area.
Okay. Thank you. And did we have any other questions in the queue?
We don't, Julie.
So the one thing I would say is if any of your offices are interested in completing, you know, instituting a navigation program, I think it's great to, you know, contact your MPRO staff, work with them, and, you know, I think they're equipped to help you. But it's also okay to contact us here at the state office as well. We do this type of consulting, both myself and my colleague, Mary Lou. We have worked with lots of provider offices, you know, talking to offices about what is their office structure, what resources do they have, who is their patient population, what might be the most helpful interventions. So if this is something you want to do, it's great to work with MPRO, but it's also great to give us a call. Because this is a part of the services we offer here at the state. And we've got lots of experience. We've done this with lots of practices. So we have ideas of things that worked and didn't work in other practices, and can share that with you as well. And if you're interested in that, I don't know that my contact information is on this slide, but you can always contact me. This is Debbie Webster. My email address is websterd1@michigan.gov. So it's WEBST, the letter D, the number 1, @michigan.gov.
Great, thanks, Debbie. And I'll be sending around an email to all of our attendees after this session today, so I can go ahead and include your information in that email as well for them.
Great.
All right, and do we have any more questions from our attendees today?
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you got any questions or comments, please press the number 1 key. No, Julie, we don't have any callers in queue at this present time.
All right, thank you. Well, again, I'd like to thank Debbie for taking the time to speak with us today, and also thank you to all of our attendees for joining us as well. The slides from today's presentation will be available on MPRO's website and also our YouTube channel within about the next week. Also be sure to join us for our upcoming webinars on May 9th and July 11th to talk more about recommendations and resources to support breast, cervical, and colorectal cancer screening activities. And this concludes our session for today, so thank you for joining us and have a great day.
I'd also like to say thank you, ladies and gentlemen, for joining me. I'll disconnect and also have a wonderful day.